right, so my name's Nadia. I'm one of the interns. I'm going to be doing a clinical pearls talk today on EPS. Some of the stuff, Christy already, or not Christy. Yeah, you already touched on it, but it's okay. We'll still talk about it. Okay, so I'm starting with a case. It's a 21-year-old male. He has history of schizophrenia and OCD. He's coming to the ED with the complaint of a stiff neck. He says it's locked and to the left, and he hasn't been able to move it for the past hour. Medication history, citalopram 20 milligrams and haloperidol 1 milligram BID. This is what the patient might look like. On physical exam, he's alert and oriented. He appears anxious though, diaphoretic and tachycardic. His upper body and neck are rigid. The neck is locked in flexion and rotated left. His voice is normal. There's no airway compromise. What would be on your differential? I know we sort of have touched on this before, but what are some of the things that you might think about? Okay. Yeah, exactly. And then on further questioning, you might get history that he took additional medication of 2 milligrams of his haloperidol 3 hours ago to control hallucinations. So with this history and an increase in his dose of haloperidol, you might think that this is an acute dystonic reaction to it. So I'm going to talk today about overview of EPS, the 4 different types, but I'm going to be focusing mostly on acute dystonic reactions and what they are and what they might look like, and then the management and disposition of patients with this. So to start, for EPS, the key medications when you're thinking about this are those that block dopamine receptors. You basically get an imbalance of anticholinergic and dopaminergic effects. And so there's a wide range of them. There's your antiemetics, even some of your antiepileptics have been shown to cause this. Your key ones though are your first generation antipsychotics like haloperidol, but your second generation antipsychotics can also cause this. But for us in the ED, we give a lot of Reglan. So that's important to keep in mind, as well as haloperidol. And so for extrapyramidal symptoms, there's 4 different types, which I'll sort of briefly touch about the first 3 and then go more in detail about the last one. But you have akathisia, drug-induced Parkinsonism, tardive dyskinesia, and dystonia. So to start, akathisia, that's basically a subjective feeling of restlessness and a need to move. You'll basically see like an inability to sit still in these patients. They might be pacing, walking in place. It's pretty common after Reglan. There was a study that showed in the ED about 9% of those who receive 10 milligrams of Reglan actually experience akathisia. And I've already seen it myself a few times when I've given Reglan to patients. So just to be aware of it, it can be acute or chronic. You can sort of prevent it by administering the Reglan slower, like a piggyback instead of an IV push. The second type is drug-induced Parkinsonism. Basically, it's similar to Parkinson's, but it's more rapid progression, symmetry of symptoms. You'll see a relative absence of rest tremor, apparently. You'll get the rigidity and bradykinesia and gait disturbance, though, that you see with Parkinson's. And these are people that will be on their medications for like a longer period of time. It's more of a chronic issue. And then the third type is tardive dyskinesia, which basically you see involuntary and abnormal movements of the jaw, lips, and tongue. And it tends to be someone who's been on these for a longer period of time. Then what I'm going to focus in on mostly is the acute dystonic reactions. So this is basically you get involuntary contractions of muscles. It can be of your extremities, your face, your neck, and then you'll get these abnormal movements and postures. There's 7 different types that have like names. The buccolingual crisis is basically you'll have like dysarthria, dysphagia, grimacing. You can have tongue protrusion with this. Your oculogyric crisis is basically you'll have spasm of the extraocular muscles. Most commonly, like they'll be deviated upwards. Torticollic crisis, you'll see abnormal asymmetric head or neck positioning. Crisis, you'll have like abnormal contractions of your abdominal wall, hip and pelvic musculature. Obstatonic crisis, you'll see like flexion, posturing with arching of the back. And then the one that's actually pretty scary is laryngeal dystonia. And this you can have dysphonia and stridor. If you ENT were to do a look with a laryngoscope, they would see abnormal movement of the vocal cords. So they would see like decreased movement or paradoxal motion because you're basically having contraction of your laryngeal muscles. And then pseudomacroglossia is basically a sensation of tongue swelling and protrusion. And it could look like some type of angioedema, something like that. So for your differential diagnosis, it's sort of broad just because there's different types of dystonic reactions. If someone's having like an oculogyric crisis and they're having eye deviation, you might think that they're having a seizure. As they had mentioned before, you might think that they're having a stroke if they're having like posturing of one side of their body. If they're having sort of the neck spasming, the aortic colic, you could think about meningitis. Any metabolic abnormalities can cause muscle spasming. And then if they're having laryngeal dystonia or pseudomacroglossia, it might look like something more scary like angioedema or an anaphylactic reaction. So who's at risk for acute dystonic reactions? The people that have been shown to be highest at risk are those who are younger in age, male, and then if they've had any prior episode of EPS. So if you see someone like on the chart that says that they have an allergy to Reglan or to Haldol, those haven't been shown to have like true anaphylactic allergies. That's probably they had some type of EPS or dystonic reaction. So just to be aware if you're going to be giving a similar type of medication. And then anyone who receives a higher dose of medication and is more at risk. Your key medications again are Haldol and Reglan. And then on physical exam for acute dystonic reactions, the key thing is mental status is unaffected. So they'll still be responding to verbal stimuli. They'll still be oriented. They're going to be anxious and agitated often because it's very uncomfortable to have multiple muscles like spasming. And then the other thing will be localized to one or a few muscles. It's not going to be your entire body, which is key for distinguishing from NMS, where you're going to have like full body rigidity. In terms of vital signs, they will be normal, or they might be tachycardic and tachypnic and diaphoretic just from the anxiety. So this is the example. So this guy, you sort of saw it a little bit before, but he's having a buccolingual crisis, or he's having sort of his mouth spasm open. You can hear him talking.
Oh. No, you don't do cocaine or anything like
and this
that?
provider is asking him if he's having difficulty like speaking words.
Okay.
And then they gave him, which we'll talk about the treatment, but they give him Benadryl. And then afterwards, this is like 15 minutes later, and he's able to speak. So you see that dramatic improvement. Let me see if I can go back. Okay. All right, so that was sort of an example, and it gave a preview of the management. But for acute dystonic reactions, always think first about your ABCs. It's rare, but you could have laryngeal dystonia and have airway compromise from that. In terms of the specific treatments, you want to give an anticholinergic, so benztropine, which is ideal. It's harder, I think, to get in the ED. We're probably gonna have to get it sent from pharmacy. Benadryl is also just as good. For benztropine, the dose is 1 to 2 milligrams IV or IM for adults, and 0.02 mg per kg to a max of 1 milligram for kids. You redose if symptoms are still there after 15 to 30 minutes. For Benadryl, the dose will be for adults, 50 milligrams IV or IM if you don't have access. And then for peds, it's 1 to 2 milligrams per kg, IV or IM. You'll again redose if symptoms are still there. With both of these, though, you should see rapid improvement within 15 minutes. And if you're not seeing any improvement, then you're probably not treating an acute dystonic reaction. You might need to redose, though, for them to have complete resolution of their symptoms. The second line medication, you can also, as an adjunct, do benzodiazepines if you're having a significant, sort of distress from the muscle spasming to help sort of relax the muscles, but that's not going to treat the central problem and is not the key medication, is not first line. So in terms of disposition, basically, if symptoms have resolved, you can discharge them home. If they have any airway or respiratory compromise experience, you should observe them for around 24 to 48 hours, just because of the half-life of these medications and the length of time the Benadryl or benztropine will sort of last. And given if they had a recurrence of this and they had airway compromise, they'd want to be in an area that was monitored. And then you need to discharge them with 1 to 3 days of benztropine, 1 to 2 milligrams, PO/BID, or Benadryl 25 to 50 milligrams PO Q6 hours. And this is because if you think about the half-life of the medication, so if they got a dose of Haldol, the half-life of that can be is 20 to 24 hours. And there's multiple half-lives until it's out of the body. And so you need to continue them on an anticholinergic at discharge. Reglan has a shorter half-life, so maybe it'll be a shorter time period. And this would just depend on how many doses they had, if this was something that was like a one-time dose that they had this reaction, or if they had been taking it for a longer period of time. If they're on like an antipsychotic for, schizophrenia or some psychiatric disorder, you should probably talk to psych before having them discontinue the offending agent and then discharging them on an anticholinergic medication as well. So key points, always ask about medication history, because if you're not, you're probably not going to be thinking about EPS or acute dystonic reactions. So there are those 2 key medications that we see a lot, Reglan and Haldol, but there's other antipsychotics, the second generations, risperidone, olanzapine has actually also been seen with these. Keep EPS on your differential. We see acute dystonic reactions and we see akathisia in the ED, we see the other 2 types as well. And if it's not on your differential, it can look like some other stuff. And if you're not thinking about it, you probably won't treat it. And then Benadryl or benztropine is the first line in treatment. You give the dose and it's IV or IM, and you should see within 15 minutes improvement in symptoms. And if you're not seeing any improvement, you're probably not treating the right thing. Any questions?